There are pockets in the United States which have mild, experience mild situations, but they will increase because once you start seeing cases in the community being reported, one knows that there are many more cases. Testing is still a problem. At some point, we will be in a situation where we'll be able to test everybody just the way we can do a blood count, right on the spot, maybe with a 2-hour to a 4-hour delay. This technology has just not spread out in a uniform way around the country. It will. We in South Florida are experiencing delays. For example, at my hospital at Mount Sinai, we send our tests to Quest in Miramar. We're improving our turnaround time to 24 to 48 hours. That's improved, but still it's a 2-day turnaround time. And we have many patients hospitalized, the results from which are not yet back. So we need to find out if they're negative and positive, which will help us make decisions. What can we say about the reliability of testing? If a test is positive, it's exquisitely specific. It's very likely that someone's infected, but there are false negatives. There isn't a test that we do in medicine that's 100% sensitive and 100% specific. Sensitive means that everybody with a disease will be identified with that test, and specific means that if a test is positive, it can't be anything other than the disease you're looking for if it's 100%. That's what 100% sensitive and specific would mean. There is no test in medicine that's 100% sensitive. For example, I'm sure people have experienced a biopsy of a lesion that may come back inconclusive. It's not 100% sensitive. It's specific because if it comes back malignant or whatever else it shows, it can be very specific, but it's not 100% sensitive. And we're finding that out about the coronavirus test, which is a PCR test, a nucleic acid test. What I envision in the future, well, antibodies, by the way, now we're reading about antibodies. Antibodies to this virus appear approximately within 7 days after onset of symptoms. By 10 days, the probably almost 100% of patients who truly were infected with coronavirus will demonstrate the presence of antibodies. That will be helpful going forward to try to identify who has been infected and to determine what the true infectivity rate in a community or the country actually was. Using those data, we'll be able to really hone down on what the mortality rate of this is. But that's coming in, that's the future. The specific mortality rate is comforting when you learn it's low, but it's really irrelevant because we know at this point, because we know the disease can be fatal, and we know cases of patients who have died, we've read about it, and that's what's important right now. Case fatality rates, meaning the numbers of people who die divided by the numbers of people who actually get infected, will vary from locale to locale, depending upon the testing volume. The more you test, the more you find mild cases, the larger the denominator. When you determine case fatality rates, which is the numerator over the denominator, and it can vary from 1.5% to 6%, 8%. But those 6 and 8% numbers are dropping, and they will drop. My guess is it's somewhere between 1% or maybe a little bit less. You've read about drugs. I believe by the fall, we'll have some medications that will turn out to be effective. Nothing you've read about or heard about now is definitive. People talk about chloroquine, hydroxychloroquine. The president is touting those drugs as if they're cure-alls. You have to be careful about that. We do not have the data, the true scientific data that needs to be accumulated to say that these drugs are effective. They may be, they may not be. They're certainly not panaceas. As I said 2 weeks ago, they don't work the way penicillin works against bacterial infections. They may work, they may not work. I think we need to be cautious. But if they don't work, I'm optimistic that there'll be other drugs in the pipeline that will be effective. And I can tell you that pharmaceutical companies, research labs, with governments' support all around the world are feverishly working on looking at new drugs and drugs that we have available that might be effective. With respect to a vaccine, we're still months away. And it's important that a vaccine, when it is released, is deemed to be safe. It's gone through the testing necessary to show that it can be efficacious. Because if a vaccine is rolled out and it turns out that it enhances the infection rather than prevents the infection, and experimental studies have shown in other situations that vaccines, when given to animals, can make things worse. So we need to have those data in place before a vaccine is released. I believe that things will quiet down at some point. I can't say when. I think the longer we social distance, the more data we'll have showing that the curve is flattening, and then restrictions will be lifted when we find that there are almost no cases, no new cases occurring each day. Deaths will lag behind. So after cases drop and go back close to zero, there will continue to be deaths because the disease can last for 15, 20 days, and many patients may die later on in the course of the illness. But eventually, the deaths will come down. Restrictions will be lessened. And at that point, the public health will have to, and testing will be, I believe, universal, widespread. When cases are identified, the health department will quarantine those patients. They'll follow up their contacts. They'll keep the contacts. They'll test the contacts. They'll keep the contacts secluded. And this will help prevent the spread of the disease, which we sort of didn't have the luxury of doing or didn't do when the disease started appearing on our shores as well as around the world. But that's something for the future. And antibody testing will also play a role in containing the spread of the virus. So let me stop there. I'm sure you have lots of questions, not necessarily about what I've said, but about things you've experienced, and I'll do my best to try to answer some of them.
Thank you so much. So for those of you who have questions, please write them in the chat box. And I will just start off with a question because there are none there yet. So my question for you is, if somebody feels that they might have the coronavirus, they feel some of the symptoms, or they have a family member who does, what should they do? At what point should they go to the hospital, or should they call their physician? What's the best course of action?
Okay, it's a good question, Gail. That's common. That happens. I mean, that comes up all the time. Ideally, it would be great if they could be tested, because then they would know that their symptoms are caused by coronavirus. Let's say they are tested, which really is not available now. It will be, but it's not available to get universal on-the-spot testing because the emergency rooms are not doing that. And they, you could get tested, I suppose, at Marlin Stadium. I know there's testing that's, Dan, the governor said that they opened up a place on Collins Avenue. That's a potential area to get tested. You need to call, you need to have an appointment, you need to have symptoms to have a test. So let's say a test is done. You would isolate at home. If you're, because assuming you're not sick enough to go to the hospital, sick enough would be characterized by difficulty breathing, really air hunger, and then you say, gosh, I'm really sick. I need to be seen in the emergency room and possibly admitted. But short of that, and most people will be short of that, they won't be terribly sick. You isolate yourself at home. A separate bedroom if possible, separate toilet facilities if possible. Everybody in the house should wear a mask. You should wear a mask. You should use good hand hygiene, and you try to separate yourself from your household members as much as possible. But understand that when you get symptomatic, your contacts in the house have largely been exposed to the virus that you have, because the disease is contagious, particularly early on in the illness. So everyone's been exposed already. That doesn't mean that the attack rate, that people who have been exposed are all going to get sick. All of them may, none of them may. But you need to still practice social distancing in the house and semi-isolation, and no need to go to the hospital until your symptoms warrant it. Because of the lack of testing, people have said, and this makes sense, that if you have the symptoms suggestive of COVID, you might as well assume that you're infected and practice what I've said.
Okay, thank you. For those of you who don't know how to find your chat box, it's at the bottom of your screen, and you click on it, and then you're able to type a question in. Okay, so the next question is about housekeepers. So people have been asking whether or not they should allow their housekeeper to come to their home.
I think, look, social distancing means social distancing. It's easy to rationalize because some member of your family who doesn't live with you, or some friend who doesn't live with you, or your housekeeper who doesn't live with you and has been asymptomatic. It really doesn't guarantee that that individual is not incubating the infection, is not infected. So social distancing means social distancing. Everyone's going to sort of do what they want. But my recommendation would be not to allow the housekeeper to come to the house, not to have your friends come to the house. Interact with your friends on Zoom, but people are going to do what they want. It's just social distancing is social distancing. And we all can understand it. And there really shouldn't be an exception for a housekeeper. Now, if somebody is going to work in your home outside and you have no contact with them, that's different. But if you're going to have contact with your housekeeper in the home, even though you might be wearing a mask, the risk is low, but it's not zero.
Thank you. Is it safe to order takein?
Seemingly, I mean, it's unknown. I don't know that we can identify that takein food has been the source of cases. Potentially, I suppose it could be, but most people are doing it, and it hasn't been proscribed. And I really can't answer it specifically, but I think the risk is low. Again, it's not zero, but I think the risk is low. And practice hand hygiene after you take in things from the outside, whether they're packages that are delivered or food.
Okay, here's a very specific question. If you live in Brooklyn and can get to Florida safely and have a place to stay that is vacant, would you go? It will not be as comfortable as being in your own home, but there's a 5 and 10-year-old that are stuck inside there.
Would you travel? I think that it would, with respect to that family traveling, it would be safe enough for them with the risks of interacting with people at airports. So that's where the major risk is. Holding up in an apartment and practicing quarantining or social distancing in Brooklyn would be the same as doing it in Miami. Maybe there are fewer cases in Miami compared to New York. So, with respect to that, it may be a little safer, but still it involves traveling between New York and Miami, and that's where the risk is. It's in the travel. And, it's risky. It's probably riskier than staying in Brooklyn, maybe more comfortable, but it's riskier, and it's not necessarily practicing social distancing. So, that's how I would answer it. People do what they want, but I think that it would be safer for them to stay where they are if they truly practice social distancing in Brooklyn.
Thank you. The question has been asked about ventilators and what is Mount Sinai's status, and do you believe it will be able to meet the need of the public as we see more cases?
Okay. Our status right now is we have enough ventilators. We have, I think, enough in reserve, and we are training more individuals in the hospital to utilize these ventilators as we run out of respiratory therapists to take care of the ventilators that will be in use. I believe we have enough going forward. The next month is going to be critical because if you look at the data projected for Florida, we're certainly not at our peak. And I think everyone acknowledges that we have so many cases in our communities that over the next 2 to 3 weeks, we may see a much larger number of people presenting to the hospital. And the more we have coming to the hospital, the more people will be sicker and will need ventilators. Right now, I believe we have enough. We have not gotten to the situation where we've had to order more, but we hopefully we won't need to. But I believe right now we have enough. I think over the next 10 days, we'll have a better idea of what's happening because this is fluid and it's ever changing. And hopefully that the social distancing we've been doing for the last several weeks will make an impact on what's happening in South Florida.
Another physician wrote, I saw a video of an ER doctor from the New York City area who states that patients present with air hunger that is similar to high altitude sickness and that we are not treating patients appropriately with ventilation. Is this bogus?
Well, as I said, one of the indications for going to the emergency room would be difficulty breathing, namely air hunger. Now, when patients have air hunger and they get to the emergency room, the doctors measure the saturation of oxygen in their blood. And when the level gets down to about 92 on room air, then those patients are admitted. Should be somewhere between, let's say, 96 to 100%. If they're at 94% and they walk around, the doctors will, in our hospital, will walk them for about a minute. And if their saturation gets below 90, we'll admit them. At that point, once they're admitted, then they're followed. When they get to a point where their saturation gets to be so low and they clearly have evidence clinically of major difficulty breathing, they're intubated. We try to intubate patients as late as possible, but yet we're pretty aggressive in doing it. So we don't wait till they're critically ill and dangerously ill. We wait until the numbers show and their clinical appearance demonstrates that they need to be on a respirator, and then they are intubated. So I don't believe that, people who have air hunger and whose saturation or, whose data are, as I suggested, I really don't believe that down in South Florida, we're sending them home. Now, if we had a crush of patients and we were unable to admit everybody, I don't know how we would behave. But right now, that's not what we're doing. We're admitting them.
Here's another question. Is it a good sign that the positive rate in Dade has been level at about 1,000 per day for the last few days, or just a matter of testing results lagging or something else?
I don't think testing results are lagging. I think they're increasing. I think we're doing more testing. I'm reluctant to say that's an indication of our leveling off, but I'm very hopeful that it is, and it may well be. I think a couple of points on the curve just aren't enough, but over 3 or 4 days, 5 days, if we see that, then I think we indeed might be seeing the effects of the social distancing that we've been practicing, particularly here in Miami Beach, for the last 2 weeks, if not longer. So I think that I mentioned that to my wife the other day, but I'm also aware of the fact that just 2 points on the curve are not enough. We need to see 3, 4, 5 points on the curve to really have more confidence that we are leveling off. But I'm hopeful that we will be.
Thank you. When do you believe it will be safe to undergo elective surgery like cataracts?
Until the hospital sees fewer and fewer cases each day. I think that most of our resources are being devoted. Our nurses, our personnel, our equipment are all being devoted to taking care of patients who either have emergencies aside from COVID or seriously ill COVID patients. So I can't say. I think that, it could be maybe weeks to a couple of months.
Can you have a social distancing meetup outside, like in a driveway, with a couple of friends, if you keep a distance of 10 to 15 feet?
Yeah, I believe you can. I think that the virus isn't transmitted when you're that far away from people, particularly wearing masks. Now, let me say something about the masks. There's been a lot said about the masks. The masks that we make ourselves with cloth and t-shirts, etc., are somewhat protective in preventing large particles like saliva and the amount of material that comes from a sneeze and a cough penetrating the mask you're wearing. It doesn't completely stop them, but it definitely diminishes the volume. And so it keeps your contacts, people who are near you, less at risk. The masks certainly that we make certainly are nowhere nearly as effective as the surgical masks that physicians and nurses and healthcare personnel wear in hospitals, and they're not as effective as the N95 masks. So we know that, and therefore hospital personnel need to be fitted with N95s and with surgical masks, which are working quite well. And those masks should be reserved for them. For us in the community, we could do well with just the cloth masks for the protection, the mild protection that it affords. But if you're 6 feet away, a mask gives you an extra protection, but 6 to 10 feet away is certainly plenty to prevent spread of infection from person to person.
Thank you. I have a question about fever and mild symptoms. There has been some news in the paper and the internet about Advil being disadvantageous for people who are afflicted with the coronavirus. Can you comment on that?
Yes, in the beginning, there was some French data that suggested that class of drugs might be detrimental. Since then, data have not supported that. And medical organizations are not recommending that you avoid Advil, Aleve, ibuprofen, etc., which is the class of drugs called NSAIDs. So if you need to take them for reasons you need to take them, you can. And I don't think the data support that you do worse.
Can you still be a carrier after 14 days without symptoms?
Without symptoms, it would be unlikely. The people who tend to excrete the virus the longest are those who have been on respirators and who have been seriously ill. And we say 14 days seems to be the time when most people who have been infected are negative. Now, we're not testing a lot of people now because the tests really aren't available. And when somebody is positive, we are using clinical symptoms to allow them to go back to work and to discontinue the quarantining. And those clinical symptoms that the CDC has recommended and which we're practicing at Mount Sinai are 7 days after the onset of your first symptom. And if you are perfectly well without fever, cough, or any other symptoms for 3 days, 3 full days, then going back to work or discontinuing quarantining, but still wearing a mask if you work, is acceptable. Testing would be a different way of doing it, and then you would need to have 2 negative tests. But we're not doing that because we don't have the luxury of getting those results back. And for many of our people in the hospital, we really need them to perform duties, et cetera. So that's what we're doing for hospital personnel. And we're letting people who have tested positive go back to work under the circumstances that I've mentioned. So if you're asymptomatic, it's unlikely that you're transmitting the virus. If you're on a respirator, you're going to be in the hospital for longer than two weeks. And those people tend to excrete more virus and for a little longer period of time. I can't give you a definitive time when those patients will be negative.
Do you know how long the antibodies are effective for?
Well, we really don't know whether antibodies are effective. We think they are. Certainly, patients who have recovered from coronavirus have donated their blood, and their plasma has been used to treat patients who are sick. The data, very few data, anecdotal data, report that those patients who receive the plasma are doing better. They're certainly not doing worse. We haven't had enough data to support that. It stands to reason, and intuitively, we would expect that the antibody would be protective. Certainly that's the way it seemed to be with SARS, which is similar to this virus, and with MERS. With HIV infection, that's not the case. And so it's not a universal phenomenon, but we expect it would be true here, and that patients who have recovered from this disease, we anticipate will be immune. How long that immunity will last is unclear because the virus hasn't been around long enough. I mean, I don't know whether it's the same as polio or measles or chickenpox or tetanus. It might be like flu if the virus mutates. We just don't know. So those data will be forthcoming as this epidemic evolves. And, again, this is a fluid situation, and we're learning more and more as time goes by.
Somebody wrote, I read on NPR that research shows that most patients placed on ventilators still die, and ventilators themselves can cause fatal infections. Are you seeing this, or are you seeing ventilators save lives in the majority of cases? What about the ECMO procedure?
Okay, ventilators help. What ventilators do is they keep people alive long enough to give them a chance for recovery. Not everybody who goes on a ventilator dies. Most people will survive, but the mortality rate among people who go on ventilators is obviously a lot higher than the mortality rate of patients who don't need ventilators. The use of a ventilator is associated with complications unrelated to the infection that the ventilator is helping treat. Because when you're on a ventilator, you're at risk of getting a bacterial infection in the hospital, which can be fatal or serious. So indeed, ventilators have complications, but more people put on ventilators survive than die. There's no question that they help save lives and they allow people a chance to recover. ECMO, which is ECMO, which stands for extracorporeal, namely outside the body, membrane oxygenation, which is a process where blood is diverted outside the body into what is essentially a heart-lung machine or a lung machine that oxygenates the blood and returns it to the patient. That technique has grown significantly in the last several years, and it's used to treat people who have severe and prolonged but really severe respiratory failure. Patients who go on ECMO are obviously the sickest. So the mortality rate of those patients is higher than patients who don't need ECMO. It can be life-saving, and certainly it's better than not doing it. I can't give you the data in terms of what percentage of patients who go on ECMO survive versus don't survive, but the mortality is much higher if ECMO is required, but it can save lives.
Thank you. Here's a question about exercise. When you are exercising outside, since we know that the droplets can linger in the air for hours, what is the risk of infecting yourself if someone has walked by the other way and has COVID, even though not aware?
Okay.
Would you, wait, one last piece. Would you suggest masks while exercising to protect yourself?
Well, the masks are sort of recommended by everybody, or for everybody who goes outside. But the droplets really don't stay suspended in the air for hours. What happens is the droplets that are produced by a cough or a sneeze or speaking, whatever, if droplets are, when you speak, sometimes saliva comes out of your mouth, those droplets settle to the ground very quickly, within minutes. So they aren't suspended in the air. There may be particles that could be suspended in the air following coughing and sneezing. They don't seem to last very long either. And the volume of virus that is likely to be suspended is not enough really to cause an infection. If you're walking by somebody and you're far enough away, the risk is essentially nil. I don't think that's an issue at all. That's not how the disease is transmitted.
That's great news for us here in Miami. Does Mount Sinai have enough PPE?
Presently, yes. We don't have an indefinite amount of PPE. We need to continue to get replenished. So we have projected, for example, if we may have 3-4 weeks on hand, if that isn't replenished, we would run out. But we seem to be getting more supply in regularly, but on allocation, it's not necessarily guaranteed that we're going to get the equipment. We talk about this every day at a 12 noon meeting, and we hear from our supply side people. And right now, we're not dangerously low, but it depends upon how much we get going forward. So I would anticipate we're okay. I'm hopeful that we're okay, but we're still concerned.
Thank you. What products can be used to sanitize a room, such as a spray?
Well, what's very easy to use is bleach. And you can, I think the formula is 4 teaspoons for a quart of water, 4 teaspoons of undiluted bleach in a quart of water, or 5 teaspoons for a gallon of water. So 5 tablespoons. 5 tablespoons for a gallon, 4 teaspoons for a quart. That works. Now, you could put that into a spray bottle, okay, which you could have from other cleaning solutions you have, or even buy a spray bottle, and you can use that. That would be easy. I think bleach is available, and you can make your own. Now, there are some surfaces that you may not, you could damage using bleach, and you have to see. I can't say it can't be necessarily universal. And then there are some other things. You can go online and find some safe and effective detergents that will kill the virus.
Thank you. If you tested positive or had symptoms of COVID, can you get it again? And if you are no longer a carrier, can you be introduced to others who have been quarantined? And do those who have had the disease have to be quarantined?
Well,
oh, I see. If you've had the disease and you've recovered and then you're exposed to somebody else who has the disease, would you need to be quarantined again?
Hopefully, in the short run, at least, immunity following infection will be protective. This is what we hope. I addressed that issue. We don't know 100%, but intuitively, we believe that. And indeed, antibody testing is probably going to be, going forward, is probably going to be a marker for allowing people to go back to work, to circulate, to leave the home. So that may be, that's probably what's happening when we have antibody testing universally available, which could be in a few months. Because antibody testing is available. It's just a matter of having the reagents to do the testing. So I believe that for the short run, recovery from COVID-19 will give us immunity and allow us to interact with people who are infected without having to worry about quarantining. We don't know that yet, but likely that will happen based upon our experience with other infections. Does that answer the question? I think so. I think it should.
Okay. We had this 2 weeks ago, but another same question. What is your advice about handling your groceries? Should we wash products, wipe cans?
I think it's optional. I mean, I don't think we have any proof that groceries can transmit the disease. We know the virus can survive on surfaces. We know that infection following contact with surfaces might confer a lower viral dose than if you get it from coughing or sneezing. But I think it makes sense to think about wiping down the food, washing the food if possible. I mean, it gives one a comfort level. I don't think we can answer that question 100%, but it's really an optional question, and it's not like you definitely have to do it. People feel more comfortable doing it.
Thank you. Okay, another question about masks. What is the bottom line on these masks? Is it to protect ourselves or others? Do the surgical masks we order online count, the pleated ones?
Okay, surgical masks that are available for healthcare workers usually filter out between 75 and 85% of what the N95 masks filter out. They're effective. They definitely decrease the risk of infection. The masks that you buy online, I can't really speak to. I don't know that they have the same specifications as the surgical mask that are provided for healthcare workers. They may or may not. They will help prevent, if they do have the same specifications, they certainly will protect people from getting infected, because this is a droplet spread, and the droplets are largely contained by a person wearing a mask, and you're prevented from getting exposed to droplets from someone else. Now, that doesn't protect your eyes. So in the hospital, healthcare workers also have eye protection when they take care of sick patients, because if they were to cough, they would generate secretions or droplets in the air, which could land on their face, and eye can be rubbed, or it can get into the conjunctiva and cause infection that way. So that's why their eyes are protected. When we wear a surgical mask and we're taking care of a patient, we don't usually have eye protection. That's something I probably should add. So if you're in the home and you're taking care of an ill person, well, you really should try to avoid contact with that person. But if you have to, you should put glasses on if you can, to try to protect your eyes the best you can.
Okay, I think that is, wait, we just got one. If my son's family in New York all had the COVID, can they come to Miami without having to be quarantined for 14 days in Florida if they have been quarantined in New York for 14 days post-disease?
Okay, they really don't need to be quarantined based on that. If they have proof that they've been infected and they've recovered and they've come to Miami or traveled anywhere, they don't need to be quarantined. That doesn't mean that they won't be asked to because they're coming from New York, and public health can't confirm the fact that their test is positive. But if they have proof of the test, they might, I mean, I'm not sure that it's not all, the quarantining is not all that restrictive. I don't think yet we have followed every traveler and checked on them and to see whether or not they are quarantining, but they don't need to be based upon their own safety and the safety of others.
Here's a question about, I think you may have mentioned this toward the beginning, but are you seeing positive results from the combination of hydroxychloroquine and azithromycin to treat the virus?
I don't know. I asked my colleagues who are using these drugs regularly if they think they're working. And the response was, we don't know, 50-50, we don't know. They're certainly not acting like miracle drugs. Patients on those medicines are dying, but we don't know whether they're dying less because they're being treated as opposed to not. We have no controlled data, no experimental data. Those data could be forthcoming in the next month or so, but they're not available yet. Be forthcoming in places doing studies as such. And there are studies like that ongoing.
So here's a question about wearing masks in public. Since we've been asked or told to wear masks in public, what is your advice on how often they need to be washed and at what point it is deemed to be infected?
At what point what?
It's deemed, as the mask considered unclean or infected?
I mean, I think, it depends. It depends on the state they're in. I think you should probably wash them regularly, maybe every couple of days would be enough. I don't think we really know. I mean, if you're taking care of a patient with COVID, I'd wash it every day.
Actually, I'm just going to share with the group here that Dan Gelber, our mayor, sent me a picture yesterday of one of those kippas that you get at synagogue. That's just the regular cheap kippah that was put 2 holes in the sides and rubber bands tied through. And the kippah fits on perfectly as a mask. So people are getting pretty creative about the kind of masks that they use.
The masks that we use have the material that we use. The tighter the material, the more effective it is, but the harder it is to breathe through. So there's a trade-off. I think that masks will protect against gross contamination. I think you have to consider their value with that in mind.
I think that is the last question we have gotten. So is there anything else that you want to share with the group?
I just would say that, listen to Fauci and
Yeah.
listen to BRICS. Those are the people you really have to listen to because they're staying on point and understand that this is a fluid situation. So recommendations by the CDC and by the epidemiologists today may change tomorrow. So, I mean, and understand that it's based on the changing data that are collected. What we do know is what we've experienced. And what we do know is what other countries have experienced. And we have to extrapolate our experience to theirs. So that's probably how I should end up. And, a lot of the questions that we've discussed will be on the internet, and you can look on the internet, and some of the answers may change as we go forward.
Well, you are our local Fauci. And so we are so grateful to you for being our local expert and for sharing so generously with our community and for being there on the front lines and taking care of our population. I want to just conclude on a Jewish note. Of course, we have a major holiday coming up Wednesday night, and we are all going to be celebrating it in a very different way than we are accustomed to. I know usually in my home, we're moving furniture and setting the table by this time, a few days before the holiday. But now we're going to have a very small Seder and Zoom in people from family members from around Miami and even California. And I'm sure many of you are doing alternative type Seders as well. But the real point of the Seder is to focus on hope. We look backwards in order to look forwards. And so for Jews, hope is really grounded in memory. And we experience this holiday to remind ourselves that redemption is always possible. And so I hope that this holiday, even as it's diminished in some ways, will also be an opportunity to reach out to people and to try to find joy in celebrating the freedom of our ancestors and find ways to reach out to other people, because as we know, social isolation is also a public health hazard. So I really invite you to avail yourself of some of the opportunities the synagogue is offering. Thursday night, we have a community Zoom Seder, which should be a lot of fun and an opportunity to connect. And I wish you all a healthy, hopeful, and joyful Passover. Thank you for joining us this morning, and thank you, Dr. Ratzan.
Thank you, Gail.
Have a great day, everybody.
You too.